pressure management and acute neurological emergencies. We kind of touched on that a little bit earlier, but she's going to kind of break it down a little more for us. Margie, take it away.
Thank you. Thanks, guys, for coming today. We really appreciate this program has expanded greatly, especially this neuro workshop that we're having. It's like doubled or tripled in size since last year, so it's only the second year that we've done it. We really appreciate your attendance. Thank you. So, as Winnie said, I'm a nurse practitioner in the neuro ICU. I love my job. It's one of the best jobs I've ever held. So hopefully I'll continue there for many more years. My talk today is blood pressure management and acute neurological conditions. I'm going to have to do two things, run this and run that. So forgive me if I'm a little slow here. Forward. There we go. So my objectives today are to define appropriate blood pressure parameters according to the guidelines for each neurological condition that I cover, summarize why we use each particular blood pressure and that we utilize for each neurological condition, and apply the knowledge. I want you guys to be able to apply that knowledge that you obtain here in this lecture in your everyday practice. I have no disclosures at all. First, we'll start off basic. What is blood pressure? Blood pressure is the force of the blood against the walls of your arteries as it circulates through your body by your heart. And without a blood pressure, your body wouldn't be able to get the oxygen that it needs to survive. And blood pressure is extremely important when we're discussing neurological injuries because the brain needs oxygen too, just like any other organ in your body. And your blood pressure needs to be regulated because too high a blood pressure can cause hemorrhage and too low a blood pressure can cause ischemia, which can lead to infarction. So a few important facts. As somebody said earlier, approximately 1.9 million neurons die each minute. But how do we know that our brains get enough perfusion and enough oxygen? So there's a calculation called the cerebral perfusion pressure, and we use this every day in the ICU for patients that have EVDs in, and it's the net pressure of blood flow through the brain. So a CPP is regulated by two balancing opposing factors, one being your mean arterial pressure, which is a force of the blood that's trying to get into your brain, and then your intracranial pressure, that is the force keeping it out. So a normal CPP is 70 to 90 in most adults. Sometimes we'll drop it down to 65. But in order to calculate our CPP, we have to know how to calculate our mean arterial pressure. Being in the ICU and most hospitals, monitors now actually give you the mean arterial pressure, but it's good to know just the calculation. It's your systolic plus 2 times your diastolic divided by 3. There we go. So some of the neurological conditions that I'm going to cover are ischemic stroke, intracranial hemorrhage, subarachnoid hemorrhage, posterior reversible encephalopathy, and spinal cord injuries. So first we'll start off with ischemic stroke. Here's like a list of, our definition of ischemic stroke. I know you all know what ischemic strokes are. Just so you know, that can be caused by cerebral thrombus, which is the development of like fatty plaque within the vessel. And it also can be from a cerebral embolism that actually comes from the heart. A piece breaks off and it goes throughout the brain circulation and ends until it can't pass anymore through the vessel. So that's the usual cause for that is atrial fibrillation. So annual incidence of stroke is 780,000. The calculation's it's probably a little bit higher now. And stroke is the 5th leading cause of death in the United States. Acute ischemic stroke is the leading cause of disability, medical expenditure, and ICU admissions nationwide. So there's 3 types of ischemic stroke patients that I want to discuss. One is our medical managed patient, where we don't do any type of therapy, IV TPA or thrombectomy on. IV TPA only patient, an endovascular therapy patient with or without TPA. Oh, I missed that, sorry. Got to do both. So first, our medical management patient. Recommendations are to allow permissive hypertension for these patients. We're going to allow their blood pressure to go up as high as it needs to. Unless it's above 220 or 120, we're not going to touch their blood pressure. This blood pressure should not be treated, like I just said, unless they're above those parameters or these patients have other acute problems. If the blood pressure is indicated to be treated, we need to proceed cautiously by only lowering that blood pressure by 15% in the first 24 hours. The blood pressure, this higher blood pressure is an attempt to continue to perfuse the brain and prevent any further ischemia or infarct. But keep in mind, when we're lowering that blood pressure, any lower blood pressure can worsen that ischemia. These patients also need to be monitored for hemicraniectomies, and that's where you remove the skull and let them swell outward, so that will help with that brain compression. These parameters have not been changed in the guidelines for many, many years, as described earlier by Kiffin. Next patient is our IV TPA only patient. The recommendations are there was randomized clinical control trials for IV TPA, and the systolic blood pressure that they used for those trials were less than 185 and a diastolic of less than 110 before treatment, and then 185 over 105 for the first 24 hours. And those actually are our American Heart Association guidelines. So those are what we follow today. There were also multiple studies to suggest that there is a higher risk of hemorrhage after IV TPA if the blood pressures are elevated above those. That exact blood pressure is unknown though. So there are many research studies relating to TPA. However, one that applies here today is the post-TPA blood pressure elevation and its association with hemorrhagic transformation. This was a randomized controlled trial of TPA versus a placebo in ischemic stroke patients. They hypothesized that the acute size of the stroke, like the initial stroke size, would be larger and the blood pressure would be higher in the patients that converted to hemorrhagic transformation. So they assessed 97 patients over a period of 2 to 5 days after the infusion. So when they examined the results of this, the parenchymal hematoma was more frequent in the TPA patients as opposed to the placebo patients, 11 in the TPA and 4 in the placebo patients. They also found that the parenchymal hematomas in those patients that had the hemorrhagic transformation, that the size of the stroke initially was larger in those patients as opposed to the patients who got the placebo. So as Kiffin explained earlier, that size of the stroke will cause hemorrhagic transformation or is a risk factor. So given this large strokes, we try to avoid giving TPA. And the study concluded, I did want to tell you that the baseline blood pressures in both of these groups were exactly the same. There was no difference. However, throughout the 24-hour period, the TPA patients that had this hemorrhagic transformation, their blood pressure was 18 points higher than the placebo group. So the study concluded saying the size of the stroke as well as blood pressure was a factor in their hemorrhagic transformation. Trying to do both. Okay, next is our endovascular thrombectomy patients with or without IV TPA. And the IV TPA, if it was administered to these patients, the guidelines state that it's reasonable to maintain a blood pressure less than or equal to 105 or 180 over 105 during the first 24 hours period after the procedure. Those who undergo a successful reperfusion, it is reasonable to maintain that blood pressure at a level of less than 180 over 105. If no IV TPA has been administered, the optimal blood pressure management is variable, and it depends on patient factors, the degree of reperfusion, the TICI score. The higher the TICI score, the higher reperfusion. So if it's a TICI score 3, they have complete reperfusion of that area of the brain, and also the interventionalist input. They are the ones that are in doing the angio. They can see how much stenosis or athero the patient actually has to see if they need to require a little bit higher blood pressure. So practice vary between normal tensive goals, a 20% reduction from their blood pressure at admission, and also permissive hypertension. So patients that can't be reperfused at all, they can't get that clot out, we're definitely going to have a higher blood pressure in those patients in order to try to perfuse that area, just like as if we did nothing to the patient initially. So there's very limited data out there right now to guide the blood pressure management in our post-thrombectomy patients, yet I'm sure there's studies coming down the line to look at the blood pressure management of those patients. So no standards yet. I did speak with Dr. Nima. He says he likes to keep our blood pressure, his blood pressures less than 140 in these patients. So I'm sure other factors are included in that. So there are 2 studies, trials in regards to thrombectomies. They didn't actually look at the blood pressure management in thrombectomies. However, they did examine thrombectomies and time frames and other things. The ESCAPE trial used the blood pressure greater and equal to 150, and it's probably useful in promoting and keeping collateral flow adequate to the arteries that remain occluded. So that's one study that had a blood pressure parameter within it in regards to thrombectomies. And also the DAWN trial that was talked about earlier, its protocol recommended a blood pressure less than 140. So those are things to, maybe they'll use a couple of those blood pressures when they're starting to look at the blood pressure management post-thrombectomy. So, oh, sorry, forgot to move the slide again. Next is our hemorrhagic stroke patients, and you all know what a hemorrhage is. It's blood spilling into the brain. The incidence is 25 out of 100,000 per year. It's the second most common stroke, and it's more frequent in African Americans, Asians, men, and people over the age of 55. So through my research that I did, and I got several studies sent to me and a few PowerPoints sent to me, one of the main goals in treating hemorrhagic stroke is to prevent expansion of that stroke further and prevent further neurological damage. So when I looked at all this information that was sent to me, early hematoma growth occurs in 30% of ICH patients within the first 3 hours of onset. And that causes significant deterioration in these patients. Increased 30-day mortality with admissions MAPS greater than 145, and this is attributable to the higher risk of hemorrhagic expansion during the first 3 to 4 hours. And also even 1 cc larger of a stroke has the likelihood of a 7% increase in worse clinical outcomes. So avoiding that hemorrhagic transformation is key in these patients. So studies have conflicted over whether elevated blood pressures predispose patients to hematoma expansion after ICH. There's several recent studies that have went on that studied the efficacy and the safety of aggressive blood pressure lowering in acute ICHs. One was the INTERACT-2 trial. Patients were treated if their blood pressures were between 150 and 220, and they were treated initially within the first 6 hours of onset. It compared the aggressive blood pressure group, less than 140 group, compared to less than 180 group. Their GCSs need to be 6 to 15, and the goal of this study was to get that blood pressure down to less than 140 within 1 hour of being randomized, and they had to maintain that blood pressure for 7 days in this study. So the medications that were used were ACE inhibitors, diuretics, topical nitrates, and the outcome that was measured after this study, the primary was the modified Rankin scale of 3 to 6 at 90 days. So I'm not going to go over the secondary ones here. Guys, keep forgetting to move this thing. Jeez. Okay, so the results of the INTERACT-2 study. There was no significant difference in the primary endpoint of death and disability. There was the modified Rankin score, 3 to 6. In the intensive blood pressure group, the less than 140 group, there was 52% compared to 55.6% in the standard group. That's where those blood pressures are the modified Rankins scored. So there also was a trend of improvement, functional outcomes within the less than 140 as compared to the less than 180 group. The mortality was similar in both, and the hematoma expansion was just a little bit more, 1.4 cc's more in the higher blood pressure group, the less 180. So what was the results or the response to this INTERACT-2? The American Heart Association changed their guidelines for hemorrhagic stroke that systolic blood pressure less than 140 is safe and can be potentially effective in improving functional outcomes in patients similar to those that were enrolled in this study. Then came along another study called the ATTACH-2 trial. This is with an antihypertensive treatment of acute cerebral hemorrhage study. These patients were randomized in 4.5 hours to 2 targets. The first blood pressure group was 110 to 139, and the second group was 140 to 179. Let me turn the slide so you guys can see what I'm talking about. The GCS had to be between 6 and 15. The ICH had to be less than 60 cc's, and the blood pressure had to start within 3 to 4.5 hours of the time of onset. And the study group, the less than 140 blood pressure had to be within 2 hours, and it had to be only maintained for 24 hours in this group. So the medications used during this trial was Nicardipine, followed by Labetolol, as well as diltiazem, EPIDEMIOLOGY, and its outcomes that were measured, the primary outcome was a modified Rankin of 4 to 6. And its secondaries were pretty similar to the previous study as well. So when looking at these results of the ATTACH-2 trial, the modified Rankin was in the intensive group where they lowered the blood pressure down, the 100 to 139 was 38.7, compared to the higher blood pressure group was 37.7. So there was hardly any significant difference in those two. And so they looked at the modified Rankin of 3 to 6, similar setting, no difference. So they're saying in the ATTACH-2 trial, there's no difference in the blood pressure groups, less than 140 or less than 180. Oh, Jesus. Okay. Okay, so no significant difference, I'm on the same one here, when using the ordinal analysis based in the Rankin shift. The mortality was similar in both groups, but the hematoma expansion greater than 33% was just a little bit higher in the ones that we allowed to go up to 180. So 24% in the standard blood pressure group as opposed to 18.9 in the intensive blood pressure group. So, however, when you're lowering somebody's blood pressure down, there's a possibility to have renal adverse events. And that's what they found in this study, that when you apply a more aggressive blood pressure management to try to achieve hemostasis, then it can potentially impact the kidneys or impact the renal perfusion and hurt the kidneys. So the rate of renal adverse events at 7 days after these patients were randomized were significantly higher in the lower blood pressure group. So it was a 9% in the lower blood pressure group as opposed to 4% in the standard blood pressure group. So current guidelines are, as we said earlier, the American Heart still has that blood pressure goal of less than 140. Patient, these are current guidelines. Patient, as Kiffin said earlier, hopefully they match up with what she has said. Patients presenting with 150 to 200 blood pressure, lowering those patients to 140 is safe and may be effective in functional outcome. But when patients come in with blood pressures greater than 220, there's not really any target. It's less clear on what to do for these patients, but adding antihypertensive IV medications is acceptable and is reasonable for these patients. However, the Neurocritical Care Society just recently came out with new guidelines that they haven't been adapted yet by the American Heart Association. And this was after the ATTACH-2 trial finished, that they're recommending a less than 180 for hemorrhagic strokes. I'm sure there's other components that are involved in that, but that's what I have right now. So the American Heart has not updated their guidelines yet for this. So next, the topic is subarachnoid hemorrhage. I'm not going to go over a whole lot on this slide. Jeez, Louise, just keep telling me. You'll press it? Yay. So we all know what subarachnoid hemorrhage is. 80% of them are spontaneous, non-traumatic, and result from aneurysm rupture. There's other causes for aneurysms subarachnoid hemorrhage that are non-aneurysmal, like in perimesencephalic subarachnoid hemorrhage, which is venous trauma, dissections, vascular malformations, and vasculitis. There's 30,000 people affected every year from subarachnoid hemorrhage, and there's a higher incidence of 2 to 1 in women than men. African Americans, Hispanics, and people over the age of 55. Don't really want to get to 55 yet. So, current guidelines. Did you do it? Hey, okay. Current guidelines are to maintain a systolic blood pressure less than 140, and this is typical prior to securing this aneurysm. We don't want any rebleeding with these patients. So once the patient's aneurysm is secured, whether it be most likely from coiling, our goal is to maintain good cerebral perfusion, and our blood pressure goals are going to change. We're going to liberalize those goals on those patients. Now, if the patient is indeed in vasospasm, blood pressure goals change again. We're going to be permissive hypertension with those patients. We're going to allow those blood pressure up to 160 over 220 or 180 over 220. And it's actually up to your neurointensivist where to keep these blood pressures. And how we get those blood pressures up that high is we could use vasopressors, blood transfusions, IV boluses, things like that. According to the Neurocritical Care Society, 70% of patients experience some clinical improvement with these elevated blood pressures. So, and the goal that they had was like 160 to 180. So these patients, the vasospasm improves and the neurological exam improves. So, and again, avoiding hypotension in these patients is key. It helps prevent any kind of secondary injury. Next. Yes, okay. So now to make things a little bit more confusing. So if you have a low-grade Hunt and Hess score, we all know the Hunt and Hess score is an aneurysm subarachnoid hemorrhage grading. I don't know if you guys can see it down there at the bottom. 1 is your very low risk patient. They maybe have just a small headache. They're not confused. They have no weakness, anything like that, just a little headache. So the higher grades are your more severe, unconscious, comatose, things like that. So if you have a low grade Hunt and Hess score, you're going to keep that blood pressure less than 140 because there's less chance that patient's going to have a real high ICP. So, and then patients that have a higher grade subarachnoid hemorrhage and that are sleepier, you're more concerned about the patient's ICP. So you want to set those blood pressure parameters just a little bit higher. So I have 3 patients here. Yes. So the first one's a Hunt and Hess of 1. So you're very low subarachnoid hemorrhage. You've got a systolic blood pressure goal of less than 140. So how we calculated things earlier, your blood pressure is 170 or 125 over 70, which makes your MAP 88. If their ICP is only 5, it makes their CPP 83. So you MAP minus your ICP. So if you use that same blood pressure goal for a patient that has a Hunt and Hess score of 4, if you can see here, it makes their CPP 68, which is less than what is recommended. So if we raise that blood pressure goal on that Hunt and Hess patient raise it up to less than 160, their blood pressure is 150 over 90, their MAP is 110, if their ICP is 20, we're still within goal with a CPP of 90. So we play with that a lot in our ICU, where to keep blood pressure parameters and goals just so we can maintain that cerebral perfusion. So there was rebleeding is a major concern of subarachnoid hemorrhage. So there was occurs in about 4% of patients within the first 24 hours, 8% within 72 hours, and 20% within the first 2 weeks if they're unsecured. If you're securing, it's much different. So the risk highest, of course, being on that first day that they bleed. So evidence suggests that early repair and vascular treatment of these patients helps reduce that likelihood of rebleeding. Other evidence has found a statistical significance in the correlation of blood pressures less than 160 as a risk factor, or greater than 160 as a risk factor for rebleeding patients with unsecured aneurysms. So follow your orders, make sure everything's perfect with your patients in regards to blood pressure on these patients. So our next topic is posterior reversible encephalopathy syndrome, or PRES. It's a syndrome of acute onset neurological symptoms due to reversible subcortical vasogenic edema. And this occurs secondary to the inability of that posterior circulation to auto-regulate in response to changes acutely in your blood pressure. So I don't know if, the CT scan there, it's a CT without contrast. The bilateral posterior hypodensities is consistent with a patient with PRES. The diagnosis is typically made clinically with an MRI of the brain often, and it reveals hyperintensity of the T2 weighted imaging there on the, this would be on the right for you guys. So 5 etiologies for PRES. It's divided into 5 categories. Severe hypertension, 61%. People taking immunosuppressive medications can cause PRES. Eclampsia, lupus, kidney failure, postpartum hemorrhaging. And all these patients are altered because of their hypertension. So the treatment for PRES, you're going to eliminate the inciting factor, take away what's causing this posterior reversible encephalopathy. So studies suggest that decreasing your systolic blood pressure by 15 to 20% in the first 6 hours is what's recommended. Hypertonic saline, supportive care, anti-epileptics may be warranted. Many cases resolve within 1 to 2 weeks after controlling the blood pressure and eliminating that inciting factor. Some cases may persist to cause permanent damage in the form of visual changes or seizures. Though uncommon, I haven't seen in our ICU yet anybody pass away from PRES, but it can cause progressive cerebral edema, compression of the brainstem. They can actually have intracranial pressure as well as intracerebral hemorrhages from this. Okay, next is spinal cord injuries. So approximately 10,000 patients per year suffer from spinal cord injuries. 200,000 patients currently reside in the United States, either paraplegic or quadriplegic. It's male predominance, 4 to 1, and the median age is 37 years old. And its etiology is listed there, 39% from motor vehicle accidents. Even though we don't care for a whole lot of patients with spinal cord injuries at Baptist, but it's just good to know some of this information. So spinal cord injuries also require perfusion, not necessarily just to the brain, but also the spinal cord. So the data is controversial. There's not really any set parameters out there right now in regards to spinal cord injuries. One of the many complications to acute spinal cord injury is neurogenic shock, bradycardia, and hypotension. And this is secondary to a sympathetic failure associated with that cervical and high thoracic cord injury. We manage bradycardia with enteral albuterol, IV beta agonists, scopolamine, atropine, and even possibly pacing. Our last spinal cord patient we ended up having to get her paced. Treatment for the blood pressure is IV crystalloids, blood transfusions, vasogenic meds or vasoactive meds, and just to maintain a normal tensive in that patient. So across institutions, there are protocol. Most of them are using a protocol to keep their mean arterial pressure greater than 85 to eliminate any kind of secondary ischemic cord injury. So pharmacology, for the lack of time, I'm going to go over just the Labetolol, Hydralazine, Nicardipine, and Cleverprex, medications that we use to bring the blood pressure down. So Labetolol, it's a third generation selective alpha-1 agonist and a non-selective beta adrenergic antagonist. It has vasodilatory and antihypertensive properties. It's less likely to dilate the cerebral vasculature. It's given in an IV bolus. As you all know, it's 10 to 20 milligrams over 2 minutes. We can also give it as a drip, 2 milligrams every minute, and titrate up by 1 milligram every 10 minutes to a max dose of 5 milligrams a minute. And its side effects are scalp tingling, dizziness, nausea, vomiting, and bronchospasms. So we need to be very cautious when we're giving this to CHF patients as well as COPD patients because it can cause bronchial constrictions. Hydralazine is another medication. This is a peripheral artery vasodilator. It causes relaxation of the blood vessels, which is carrying blood away from the heart and towards all of our organs and tissues. So it affects the calcium movement within our vessel. Calcium is what causes our muscle contraction. And therefore, when we use hydralazine, it disturbs that movement of calcium and causes that smooth muscle just to relax. So we can give 5 to 10 milligram every 4 to 6 hours. Can cause headaches, nausea and vomiting, loss of appetite, diarrhea, and a fast heart rate and chest pain. We like to use this medication if our patients have a lower heart rate because this does not affect their heart rate. Nicardipine, we use this, I think every patient's room has this running. It's a calcium channel blocker. It inhibits the calcium influx into the vascular smooth muscle, the myocardium. It produces like a peripheral and coronary vasodilatation. We start at 5 milligrams an hour, and we increase by 2.5 milligrams every 5 to 15 minutes to the desired blood pressure. Its max dose is 15 milligrams an hour, and we use the minimal amount of medication to achieve the blood pressure goal. Last drug is Cleverprex. It also is a calcium channel blocker. We start the infusion at 1 to 2 milligrams an hour. You double your rate every 90 seconds until you're close to your blood pressure goal. And then you increase in smaller increments every 5 to 10 minutes until you achieve the blood pressure that you want. Its max dose is 32 milligrams an hour. Its advantages, it's less volume than what Nicardipine is. So some of our CHF patients, we like to use a lower volume in these patients. And also it is, has a larger therapeutic window. Its half-life is only 1 minute. Contraindications is hypertriglyceridemia. It can cause severe aortic stenosis, it's contraindicated in patients with aortic stenosis, and soy and eggs. So administration keys to this is it's lipid-based, so you have to change that tubing just like you do on propofol every 12 hours. And these patients have to have triglycerides monitored daily just to make sure they're not rising and off the wall. So I'm finished. take-home points of this lecture would be to know your blood pressure parameters, know your orders, know why your blood pressure parameters are where they're at. And if you don't, just ask somebody, why are we 140 instead of yesterday we were 180? So use the least amount of medication, IV medication to achieve the goal that you want, the goal blood pressure, and avoid hypotension because it's equally as important as hypertension. And anticipate what medications you're going to need at the bedside. If you have things ordered PRN, get them up, get them on the unit. Anticipate having to use those medications. And here are my references. Does anybody have any questions? Thank you. Okay, I got almost set up. I got her. She's ready to go, but she's got to do the same thing.
Okay. So I'm going to introduce our next speaker. She's also a nurse practitioner in our neuro ICU, and this is Amo Keakopa. And she's also been with us since the inception of our program and kind of helped us open, kick things off 5 years ago. So Amo's going to talk about ICU delirium. And this is a really interesting topic, and I think it probably affects all of us if we're nurses to a great extent. All of these patients, especially people who are being woken up every hour for 21 days maybe, have a little bit of delirium. So this is something that we can all sort of learn from. Amo, take it away.
Good afternoon, everyone. We've talked about stroke, more stroke, had lunch. We're kind of tired, and this is the perfect time to talk about delirium, right? All right. Get going here. So the objectives of this talk are define delirium, separate it from other causes, review the importance of early detection of ICU delirium, as well as prevention and management, identify and review validated delirium assessment tools, and hopefully incorporate them in our care, identify modifiable and non-modifiable causes of delirium, and then apply multifactorial non-pharmacological strategies to prevent, reduce, and manage delirium burden in our critically ill patients. And then we'll touch a little bit on the limited role of medications in delirium management. So what is delirium? The National Institute of Health defines it as sudden severe confusion and rapid changes in brain function that occurs with physical or mental illness. There are 4 domains to look for in a patient who's acutely delirious. It's usually the disturbance in consciousness, change in cognition. There's always periods of fluctuation, whether a little bit more lucid in the morning, a little bit more confused later during the day. And then there should be also some HNP or lab documentation showing the cause, the physiological consequence of, or a general medical condition that could be causing them to have this delirium. For this, the purpose of this discussion, we'll talk mainly about ICU delirium. So many terms out there that are often thrown around in the ICU, sometimes correct, but sometimes they lead us a little bit off, astray in how we manage these patients. These include ICU psychosis, acute confusional state, sundowning, altered mental status, toxic or metabolic encephalopathy, acute brain syndrome, ICU syndrome, just to name a few, but there's so many. Now, dementia is a very well-known risk factor for delirium, and I focused on this slide on dementia because it's really important to differentiate between a patient who has dementia versus someone who's actually acutely having delirium. And also a patient who has dementia can have a delirium also, and so you should be able to, kind of figure out how to treat them. I'll just highlight a few because this is a little bit of a busy slide. In delirium, the patient is, there's impaired function of neurons, which is not the case in dementia. And then, like we talked about a little bit, there's waxing and waning of symptoms. A patient with dementia develops symptoms over time and progressively worsens cognitively. EEG findings are usually show a slowing in delirium. However, in dementia at baseline, they can be normal unless the patient really has advanced disease. And then recovery in delirium is good if treated on time, technically reversible, but you can't, in dementia, these patients usually worsen over time and you can't reverse the symptoms. Okay, the clicker. Okay, signs and symptoms, just briefly. These patients usually have cloudiness of consciousness, disorientation, inattention, illusions, they're confused, climbing out of bed, hallucinations, fluctuations of consciousness like we talked about a little bit. Some have just depressive state, like flat affect, apathy, they're withdrawn, they're not participating in any activities. And then other neurological symptoms that have been associated include some dysphagia, tremors, motor abnormalities. Delirium is classified as either hyperactive, hypoactive, or mixed. In a hyperactive patient, it's self-explanatory. They are anxious, restless. Those are the ones pulling out everything in the ICU. Rapid emotional changes, hallucinations, etc. In hyperactive states, they have a flat affect, they're withdrawn, apathy, they're sleepier than usual, they're not participating in any of the activities, and you can have a mixture of both. And believe it or not, in ICU, you mostly see hypoactive and mixed states. And because of that, delirium often goes undiagnosed and untreated, but has long-term effects on these patients. Epidemiology, up to 30% of hospitalized patients have been reported to develop delirium. The statistics are even higher for ICU and mechanically ventilated patients, up to 80%. I mean, that's pretty big. Most literature investigated so far doesn't really cover neuro-ICU patients, but it's really extrapolated from general ICU. And despite high delirium prevalence in ICU settings, it is frequently unrecognized and misdiagnosed. Symptoms may incorrectly be attributed to dementia, like I mentioned earlier, depression, or ICU syndrome, which is basically considered to be an expected inconsequential complication of critical illness. Duration is about plus or more than 2 days in the ICU, and the duration of symptoms are usually short-lived if risk factors are identified and treated or avoided in the first place, or patients can have long-term cognitive problems up to years. So impact of delirium, it's associated with increased burden of illness, higher morbidity, mortality, increased ICU length, hospital length of stay, and increased suffering, obviously. Up to 5 extra mechanical ventilation days just because of delirium, about 8 to 10 extra days of hospitalization, and on average, $15,000 per patient who's hospitalized with delirium, just added by the fact that they have delirium. Studies have found a strong correlation between delirium and long-term cognitive function, which I did mention that. About 50% of the patients who actually experience ICU delirium have a cognitive impairment at discharge. 1 in 3 suffer long-term effects, and then impairment has been detected in multiple patients at 3 months, 12 months after being discharged from the ICU. And if you want to put it in dollars, so it makes more sense to all of us sometimes, $4 to $16 billion cost in the US alone per annum in mechanically ventilated delirious patients alone. So it's much more than that. Now, this is a busy slide showing the many causes of, the many pathways that are associated with delirium. First of all, pathophysiology of delirium is poorly understood. However, if you look at this slide, you can kind of see some of the hypothesis of what's causing it. The main ones are inflammatory changes, reversible impairment of cerebral oxidative metabolism, and multiple neurotransmitter abnormalities. And this is another busy slide that just really goes a little bit further into what we just talked about. So one of the hypotheses believes that delirium is a neurobehavioral manifestation of imbalances in the synthesis, release, and inactivation of neurotransmitters, namely dopamine and acetylcholine, leading to instability and unpredictable neurotransmission and hence delirium. And then inflammation, as we all know, in critical care illness, patients have multiple organ dysfunction and production of inflammatory mediators, and these lead to endothelial damage, thrombin formation, microvascular compromise, and studies in animal models have even shown that these mediators cross the blood-brain barrier, and as a result, those animals were found to have EEG patterns that are similar to patients who have delirium due to sepsis. And cerebral oxidative metabolism is also found to be another cause. So we have modifiable and non-modifiable risk factors of delirium. So we'll go over the non-modifiables first, and then we'll go into the modifiable ones, because those are easy. Those would be the ones to focus on to treat these patients. So non-modifiable, we have age, dementia, baseline cognitive impairment, upper lipoprotein E4, which is also a risk factor for Alzheimer's, depression, comorbidities, severity of illness, hearing impairment, visual impairment, although you could argue that you could use some hearing aids and help those patients too. Surgery, alcohol use, and drug use before hospitalization, obviously. Now, modifiable, we have medications, more especially sedatives and analgesics that we administer, mechanical ventilation and procedures, room changes, visual hearing aids, pain, electrolyte imbalances, metabolic imbalance, disturbance, immobility, restraints, catheters, nutrition, hydration, lack of, that is. And I included the infamous Q1 neurochecks. So diagnosis is really there's 3 ways of diagnosing or identifying patients who have delirium. And it's really important that we use validated tools so we're consistent and able to actually catch it on time and treat it. The first one is the DSM-4, which is really for psychiatrists. But which one of us actually has the luxury of having a psychiatrist on staff all the time to do that for us? So there is the CAM-ICU, which is the confusion assessment method for ICU assessment, which is great and has been reproduced and used multiple times, and the intensive care delirium screening checklist. Before we go further into those, I just wanted to introduce also the scale that all of you are familiar with, which is the RUSH score, because it's always very important also to assess the sedation scale for these patients. And it's also good to set a goal for how much sedation we're gonna give these patients so we can continue to be able to assess and avoid delirium in treating them. So this is the CHEM ICU, which is really easy to administer. Most of the time you can do this in 5 minutes. The first thing to assess is acute change or fluctuation. Is their mental status changed from their baseline? You ask family, they'll immediately tell you, or you've seen them at admission, this is your subsequent evaluation, and then you know. Or has the patient fluctuated in the last 24 hours? And then if that's a yes, you go on to step 2. If that's a no, then they don't have any delirium. So then you assess their inattention. You ask them to squeeze your hand when you say the letter A, and you say you spell out one of those words. And then more than 2 errors, they probably have delirium. No errors, you go to the RASS. If they're calm, meaning calm and alert, which is a RASS of 0, then you go on to assessing number 4. But if they're not, then they're probably, if there are any RASS other than 0, then they have delirium. So it's really easy to go through. We won't go through the ICDSC because it's really busy too. But just so you know, there's 8 measures that you're looking for: altered level of consciousness, inattention, disorientation, hallucinations, psychomotor, agitation, inappropriate speech or mood, and sleep, wake, and then symptom fluctuation. The total score is 8. You get a 4. Chances are your patient has delirium, and you move on from screening them. So if we do it frequently, it shouldn't take time because then you get familiar with it. It's always important to understand the relationship between delirium, pain, and agitation. This is another busy slide, but as you can see, it depicts things that cause pain, delirium, agitation, and they all kind of feed into each other. In order to adequately manage delirium, clinicians need to also investigate and manage. Oh, I repeated that. Most patients who were in the ICU after discharge, when you interview them, they report being in pain, and that has to be really terrible when they can't speak for themselves, or they're on a ventilator. Patients who are intubated or unable to speak can be evaluated too. There's several tools out there for assessing a patient for pain. Here's one of them, the critical care pain assessment tool, which really goes by facial expressions, body movements, the vocalization, if they can, or compliance with the ventilator, muscle tensions, things that we all see in the ICU. If you're in the ICU, that probably show the patient is in some sort of discomfort or pain. So prevention is really important, since studies have shown that patients with delirium have higher mortality. Each additional day of delirium is associated with increased risk for dying. And actually, according to the SCCM, there's 3-fold mortality in patients with delirium at 3 months. And also, this was a really good study, even though it's a really small study. It had 102 patients that showed that reducing rapidly reversing delirium leads to outcomes that are similar to someone who never had delirium in the first place. So they actually had enrolled 102 patients. Delirium was reversed within 2 hours in 12% of the patients, and it persisted in 77% of the patients. The 12% didn't have any adverse effects from the delirium at discharge. and a little bit of a talk here about medications that have been tried to see if we could reduce delirium, like length of stay, or reduce coma-free days, or just medical management in reducing delirium. One study by Page and colleagues is named The Efficacy of Intravenous Haloperidol on Duration of Delirium and Coma in Critically Ill Patients, the HOPE ICU study. It was a randomized placebo-controlled trial with 142 patients. In that study, haloperidol did not improve mortality or the number of delirium or coma-free days. So there was an increased incidence of, however, there was an increased incidence of sedation and QTC prolongation in the patients that were receiving haldol. So just so you know, haldol is not really recommended for these patients. And there's several studies that have been done that followed suit. And then another study done by Gerard and others studied haloperidol and zypresidone for treatment of delirium in critical care illness. 1,100 patients were enrolled. 566 did develop delirium. And out of those 566, 89% were hypoactive, 11% were hyperactive. 184 were in the placebo group, 192 in the haloperidol, and 190 in the zypresidone. The median exposure of the drug was about 4 days. The median number of days alive without a coma were 8.5 in the placebo, 7.9 in haloperidol, and 8.7 in zypresidone. So no significant between group differences in that study too. The SCCM does suggest using Precedex, because I can't say that word, for delirium in mechanically ventilated patients where agitation may preclude weaning the patient because they're so agitated that you can't really manage them. There was one randomized control trial done, no ventilator, no significant ventilator-free days or improvement in length of stay with the Precedex as well. But at least it helps you wean the patient off the ventilator without having them thrashing all over the place, was the point of that study. And then a study done by Perry Hunt, I can say that name too, Dr. P and colleagues had 192 mechanically ventilated patients. In this study, there was an independent and dose-related temporal association between receiving lorazepam and transitioning to delirium, as depicted on that graph. Low doses of delirium over a short period of time on those patients, they were not that susceptible to developing delirium. But really, when you get to giving the patient 20 milligrams a day of delirium, those patients were 100% likely to have to be delirious. So now that we've looked at, so the recommendation from before we get to this slide, the recommendations from the PHARMACOLOGICAL guidelines are that there is no benefit for using any pharmacological protocol for treatment of delirium. Which brings us to the reason why we really have to find the non-pharmacological strategies to treat these patients. So studies have shown that prevention and management of delirium requires interdisciplinary approach with the goal of preventing and managing modifiable risk factors, as delirium is usually caused by multiple factors, obviously. The PHARMACOLOGICAL guidelines recommend the multi-component non-pharmacological intervention that is focused on but not limited to modifiable risk factors for delirium, reducing the risk factors, and then improving cognition, optimizing sleep. Again, optimizing sleep, that's a big one for me. Mobility, hearing, and vision, and optimizing like mobility, hearing, vision in critically ill patients. There was a study that was thoroughly conducted and validated by the SCCM. It's called the ABCDEF bundle, which is recommended, and it's the Awakening Breathing Coordination, Delirium Monitoring, Management, and Early Exercise Mobility bundle as a strategy of interprofessional evidence-based multi-compartment ICU management strategy aimed at reducing sedation exposure, duration of mechanical ventilation, as well as ICU acquired delirium and weakness. So it's a really good bundle to institute and use in your patients who are at risk or have delirium. When it comes to medications, less is really more. So we have to go through our patient's list of medications and avoid polypharmacy, explore medications as medication withdrawal as a cause for why they're delirious in the first place, avoid anticholinergics, avoid benzos, minimize use of sleep medications, use the lowest necessary amount of corticosteroids, opioids. If it occurs for us, mostly with the patient who's on Keppra, switch them to another anti-epileptic. Change medications like famotidine to a PPI. Check serum medication levels. Check for dehydration, electrolyte abnormalities. Reassess need for discontinued antibiotics. Less is more, do it daily, and try to eliminate these problems before they arise. So the main things in managing these patients is identifying and removing risk factors. Nutrition, hydration, constipation. How many times have we had a patient who's thrashing and throwing themselves all over only to find out that they were retaining urine? Many, many times. So promote sleep. Studies show that ICU patients sleep on average between 2 to 8 hours a day. Most of us, even healthy, cannot survive on 2 hours a day. So, and this sleep is mostly during the day. It's interrupted. It's really not quality sleep. So we need to turn off alarms, lights, beepers at night. Decrease the amount of time that we wake up the patient unless it's necessary. Manage pain, anxiety, ventilator desynchrony. Reduce the amount of time we do neurochecks when we're able to do so. Most of our patients are usually not even watching television, but you will see the television on as you pass by, and it's 2 o'clock in the morning, and they're delirious. So it's just things to be mindful of. Noise control, quiet time, consider earplugs for those who can tolerate them, promote comfort, reorient the patient as often as possible during the day, have a protocol that we can use and follow to make sure that each and every patient gets reoriented. Allow for family interaction during the day, cognitive stimulation, games during the day, music that they usually listen to, rehabilitation. So the easy way to make sure that's done consistently is to use, as I already mentioned, some sort of bundle. And like I said, the ABCDEF bundle is really great. It encompasses a lot of things. So we'll go over some of the literature that was done just to show how effective to show the efficacy of this tool. The PADIs, the SCCM literature reviewed 5 studies. One was randomized control trial, and the other 4 were before and after studies that found that non-pharmacological multi-component approach to delirium reduced delirium significantly and decreased ICU duration, delirium days, length of ICU stay, and hospital mortality. And then in a study done by Daly and colleagues in 2017 called the Improving Hospital Survival and Reducing Brain Dysfunction at 7 California community hospitals, implementing the PAD guidelines via the ABCDEF bundle in 6,000 patients, they found that increased bundle compliance was independently associated with improved survival and more delirium and coma-free days after adjusting for age, severity of illness, and presence of mechanical ventilation. So we can do this. We can all even imagine a calm ICU where none of our patients are delirious. They are easy to wean off mechanical ventilation and overall have less length of stay in the ICU and hospital and less morbidity and mortality. So we just have to flex the muscle. We can all incorporate the ABCDEF bundle. This slide just gives you an overview of how to approach these patients. Obviously, you want to have a protocolized way that we assess these patients at admission and also every day. High-risk patients, delirious patients, obviously we start, doing all the below. Treat the modifiable risk factors, target no sedation or light sedation, avoid benzos, early mobilization, pain assessment and management, try to optimize their sleep, schedule reorientation, encourage visitors, all the right things that could help them. For non-delirious patients, we have to keep reassessing them and also figure out which ones are lower risk and which ones are high risk and follow one of those tracks. I'm out of time, so I'm gonna go quickly here. So this is the ABCDEF bundle. The first part, A, is really, I can go back here. Let's see. I have more of an explanation for A here, which is pain management. You assess, prevent, and manage pain. And this is how you do it. Wait. The clicker got me there. Okay. So you perform routine pain assessments. Patients who, you make sure that all the patients are assessed, including those that can't verbalize their pain. You use your BPS scores, you use your COP, you use other behavioral measures. Treat pain and procedures, painful procedures preemptively before, the patient actually is in a lot of pain. Give boluses rather than IVs. So minimize light sedation is the key. And then you manage their agitation and sedation. Use a protocol that everybody follows. That way, we can know exactly what we're doing. Identify underlying reasons for agitation. Perform daily sedation interruptions and avoid sedation-induced coma. Avoid benzos again there and medications. And then on the BCDEF part of things, you also incorporate that into the first portion. So if you look, the next thing is B, which is spontaneous awakening trials and spontaneous breathing trials. So you wake up, you wake your patients up in the morning, you turn off their sedation, and then you put them on some pressure support. You allow them to take their own breaths, and then you incorporate that with exercise, reorientations. This can be done even on mechanically ventilated patients. Perform early mobilization. I mean, several studies have been done. I think we all know on that end that, early mobilization really helps. What's the point of saving our patients' lives and then they don't really have a great, functional outcome in the end? And then we talked about choice of sedation. using a validated tool to assess the patient daily, and then family engagement. They can play games with the patient. They can, read with the patient, help us with keeping, them cognitively challenged. So there is barriers and, there's facilitating factors and barriers when it comes to implementing a new bundle, just because for some reason now I'm selling this bundle. However, it's good to just know that you have to implement certain things to make sure it goes well if we're going to be serious about making sure that our patients don't have delirium. Daily interdisciplinary rounds are great. Key implementation leaders who come in and see where we are and what needs, education gaps and fill those. Sustained efforts, understanding the bundle's quality and strength. Barriers are usually things like fear of adverse effects. Obviously, we worry about these patients falling. They have they have catheters, they have ventilators and things that could cause that. Communication challenges, knowledge deficits, workload burden. In summary, delirium is associated with poor outcomes, and it's worse with increased duration of delirium. We have to assess our patients at admission and daily, address modifiable risk factors, use multi-component strategies, and protocolize care towards managing our patients, and avoid benzos, use sedation judiciously, and keep our patients delirium-free. Thank you. Any questions? Okay.
Thank you. Okay, so our next speaker is one of our occupational therapists at Baptist, and she comes to us actually by way of Barrow Neurological Institute, which is where some of our surgeons actually trained. So she has a great deal of experience with stroke patients, and she's going to talk to us about just a lot of things that we can do in terms of working with our patients that have maybe some cognitive impairment, and just ways that we as nurses can work with them a little bit better on the inpatient side.
Hi, everyone. They're passing out some handouts that go along with my talk, and they're really there for your reference. We won't be able to cover everything today. I'll do my best, but hopefully I'll get you started with some information. So today I'm going to talk to you about functional cognition and perception in the stroke patient. Our goals is to identify the cognitive and perceptual functional deficits in stroke or ABI, acquired brain injury. Discuss the evidence and decision-making concerning approaches to addressing cognition and perception, and describe some techniques. Oh, I have a big monitor here. This is nice. For improving functional cognition and perception in patients. Okay. So a lot of people don't know what occupational therapy is, but basically we're looking at tasks and jobs that people do in their lives. So we need our brains in order to do the things that we need to do, correct? So we identify the problems, thank you, that people are, why they're not functioning after the injury or disease. We'll either address parts of it, of the task, or all of it. It might be related to the human performance, the nature of the job or the task, or the environment. So really it's a collective synthesis of anatomy, physiology, neuroscience, kinesiology, and psychology. Okay. So we're really going to do a very brief overview because I'm sure that you folks have already kind of gone through a little bit of neuroanatomy. Sorry about that. Okay. All right. So these are the obviously different lobe areas, and if you're looking at the perfusion of the cerebral arteries, where it affects obviously anterior, here frontal, medial, middle cerebral artery, parietal, and temporal, and then PCA, occipital. Okay. But really we want to talk more about neuroplasticity. It really is basically our overall state of health, and our brains continually create and break these neural connections. Okay, as therapists, what we do is we use habituation in order to create or decrease neural responses. And our brains really are very experience dependent or use dependent, and that's why it's plastic. What you see like with stroke patients is basically the use it or lose it is very true. So if we're not practicing or doing something frequently, we're not utilizing those skills. And our cellular recovery is basically, you know, our bodies are pretty amazing. We are all superheroes. We regenerate, we heal, okay? So we want to promote that recovery by kind of altering those synapses and reorganizing the central nervous system by what we're doing with the patient. Okay, so Brodmann basically parceled the cerebral cortex with you know, little microscopic slides, and they were able to pinpoint certain areas in the brain that is very precise in a particular function, like speech and sensory and so forth. But what we're learning more about the brain is that it can really reorganize. So we have Einstein's brain, and as you can see, he has a very enhanced parietal lobe. So it shows that he has a lot of enhanced spatial and mathematic capabilities, which totally makes sense. And a little side note, they're selling slices of Einstein's brain, which is kind of a weird thing. But and then the scan you see here is a girl with a left hemispheric area totally removed. Believe it or not, they did a follow-up with her, and she was able, her family was bilingual. She learned both languages, and she was able to recover the right side of her body. So if you doubted neuroplasticity, it does happen. Okay, and this is a functional MRI looking at cortical reorganization. This is somebody who had a nerve reconstruction from the right to the left limb, and as you can see, as they're starting to innervate the left side, you can see where in the brain we're seeing activity. Okay. So when we talk about cognition and perception, we're basically thinking, we're seeing, and we get to do. So it's our ability to interact, adapt, and function. So treatment is very straightforward. It's basically providing what they're not able to do, okay? But how do we identify the exact problem and really know what they need? So in your handout here, we're gonna follow that along as I talk. The first one I have is the cognitive components description, and kind of follow along. That gives us a better idea of what we're looking at. Okay. Okay. So cognition is basically the process of acquiring knowledge and understanding. So these are all the components. We have attention, processing, memory, reasoning, all of our senses and being able to integrate all of our senses, comprehension, which is categorization, concepts, schemas, communication, executive function, which is problem solving and decision making, and our mood. Okay. So let's talk about attention. You know, attention is really quite important. It's the gateway to memory. If we're not paying attention, are we even going to store it away? Probably not. So a lot of times we always say, oh, you don't have good memory. It might be related, really is the gateway. It's the attention part. So that ability to concentrate and focus, there are very different components of attention. So there's selective attention, where we concentrate with distractions, alternating between two or more objects, sustaining attention, maintaining it over time, dividing attention, responding to multiple tasks together, and then processing that information. So on your sheet, kind of I broke up the different attention components, and to really give an example of the dysfunction that the person exhibits. For instance, you know, somebody not noticing something on the floor, or can they complete their paperwork when somebody just put something down on their desk? Are they able to have that selective attention? And a lot of times you'll have people who they're, you know, you might come into a patient room and all of a sudden the phone rings and they actually drop something, and it might be a missed kind of picked up problem is that they might be clumsy or that they've lost sensation when actually it might be an intentional thing, okay, because they've been distracted. Or you might have somebody who is a great ambulator and someone says their name and they lose their balance. And it may not be balance related, but it might be attention related. Okay. All right, so strategies for attention, kind of limit distractions. That seems fairly obvious. Reducing their stress, fatigue, maintaining them to be engaged in the activity, because you want to maintain their attention. So you may ask them, how are you doing? You know, interject, ask questions, create interest and motivation, and just let them know what some of the expectations are. I'm sorry, I'm talking kind of fast here. All right, so looking at memory, our ability to recall and recognize information, short-term and long-term, okay? It takes about 10 to 20 seconds to actually store something away into memory, okay? So, you know, sometimes we pop into a patient's room, we say, hey, you know, this is the date, and we barely spend 2 seconds with them, and we expect them to recall that orientation question. It's not enough. So we wanna make sure that they're rehearsing that information frequently. Everyone should be doing that. It helps them orient them. But we need that 10 to 20 seconds is a long time. Okay. So procedural memory is knowing how to do things, and it becomes automatic over time, like tying your shoes or riding a bike. Declarative is a conscious, intentional recall of facts and concepts, like your high school graduation. And then prospective is remembering to perform an action or intention, like a doctor's appointment. And there are other memory components like somatic, episodic, procedural, and then working memory is holding temporary information and being able to store it away for use later. So there's quite a few different components there. All right, so some strategies for memory is using descriptions, providing a synonym at the end of the sentence, having them repeat and self-talk. Again, we're trying to use that 10 to 20 seconds to store it away and encode the information. Visualization, imagery, rhymes, paraphrasing, grouping or chunking elements, creating stories, and space retrieval. Okay. Executive function is that bigger overarching ability. It coordinates everything: problem solving, planning, organization, and we need the ability to have some self-awareness in order to do this. If we don't know what's wrong or how to modify things along the way, it's very difficult to have this bigger capability. So it oversees everything and monitors for efficient productivity. So some strategies for that is organizing thoughts and environments, create maybe a tracking system for the patient, putting something in the same place, like the locations, folders, lists, developing a mapping or a chaining system. Make sure that you're facilitating self-awareness, because they can't correct a problem or make decisions if they don't know that it exists, and eliminate distractions. Okay. Reasoning is our ability to identify, interpret, and come up with a conclusion. So we want to give them information, give them some experiences so they can make good decisions. Sometimes we ask patients to do things and we really haven't provided the setup in order for them to come to a good conclusion. Okay. So the strategies for helping them with reasoning is evaluate the situation, identify and prioritize the known elements, just really consider their feelings and emotions and why, and just factor all the elements for them to come up to the decision making. Okay, and communication is our expression and perception of needs and emotions to bond, learn, obtain, and exchange information. And that comes in very different formats. It can be visual, verbal. Paralanguage is our intonation. You know, if we're very monotone, that doesn't communicate very well, or if we have high intonations and pleasure in our voices, then it definitely communicates something different. Nonverbal, written, and physical. So when somebody's having difficulty with communication, help them identify how they feel, help them identify who they're communicating with. Sometimes people don't know who they're communicating. It's different to communicate with a child versus an adult or someone you care about. And then just help them identify the best method to get the point across. So it might be an alternate method, such as a note, email, gesturing, demonstration, a drawing, a communication board. Okay. And mood has a lot to do with our ability to deal with or process a situation. It's highly related to the limbic system. That's our instinct, our mood, our basic emotions, and our drive. So it is made up of the hypothalamus, which regulates our systems, the hippocampus, which takes memory and information and spatial things for navigation, and it actually is our save button in our brain. Okay, so that is a very important area. And our amygdala, it processes the emotion and associates it with experience so that we can make decisions. So if we had a negative experience, like I hate spiders, I'm going to associate that with an experience, and I'm going to make a decision about that. Okay, so strategies for mood and coping, facilitate relaxation, maybe help them see another perspective, identify their mood or situation, and referral to somebody who is relatable to that person, whether it be a chaplain, a family member, a support group person. And I know it's talked about a lot, but address sleep and negative behaviors such as drug and alcohol use, and provide an easy way to achieve those activities and even exercise. In your handout, I also provided you with neurocognitive behaviors. Those are kind of outside of just cognition, but some tips on how you would address aggression, defiance, which we sometimes come across, hyperactivity, hallucinations, and I won't have a chance to touch on it today, but it's there for you for your reference. Okay, so a big thing is perception. I think most patients, this is missed for them quite a bit, is their ability to perceive things. So it's the organization, identification, interpretation of sensory information. So they understand and represent their environment that they're in. So of course, it's our ability to see, hear, and become aware of something through our senses. So sight, smell, taste, hearing, touch, where our body is in space, and then also our social information as well. How perception really works is there's some kind of distal outside stimulus, whether it be visual, sound, or physical. And then our senses, our sensory receptors will receive it. And then our brain's going to make a mental representation of that and be able to interpret it so we can act upon it. Sensory changes can be complicated by aphasia, which is not cognition. I want to make that clear. That's a communication problem, but it also can be related to complicated by cognitive deficits. Now, sensory changes and age-related decline really distorts our representation of the world. It leads to loss of function and decline. So we want to look at mood, motivation, sleep disorders, culture, medications, diseases, behavior changes, and anything that might disrupt them in their recovery. Okay. So talking about perception, those different sensory areas, and we're looking at vision, which is also impacted by the actual structures of our visual pathway. And then auditory, which includes not only sounds, but also vibrations in our environment. And then constancy is recognizing that the same stimulus in various situations are the same. Okay, so you really understand that the difference when you're in different situations. Haptic is touch and proprioception. Okay. And then our other senses of taste, smell, balance, pain, our internal organs. These things are really important in looking at how we interact with the world. But we're going to focus on visual perception as well today because it does relate closely to cognition. Okay. You also have a visual processing handout too, kind of this one here. Okay. So visual perception is the ability to interpret the surrounding environment, processing information that is contained in actually visual light. Okay. So we're going to see how our brains really can modify how we interpret things. So it's an example of just how mapping happens in our brain. So Andrew, could you play that first?
Take a look at this spinning ballerina. We've got a question for you, but take a second to really think about it before you answer. Which direction is she spinning? Is it clockwise or is it counterclockwise? If you're watching with a friend, feel free to ask them the same question. Got your answer? Well, if you said clockwise, congratulations, you're right. And if you said counterclockwise, I'm sorry, but you're also right. So, how can both answers be correct? As you watch the dancer, specific cells in the back of your eyes are working to detect motion, either from right to left or left to right. Since here your brain, right? It's Albert Einstein. Now take a look at this mask of Einstein. It may not make you a genius, but can you figure out if this is the front of the mask or the back of the mask? Got your answer? I'll give you a hint. The answer is relatively simple. Have you decided if this is the front of the Einstein mask or the back of the Einstein mask? Before we reveal the answer, let's see what some other people thought when we asked them the same question about the famous professor.
We're approaching this Einstein mask, and as we get closer, I want you guys to identify which is the front of the mask, which is the back of the mask.
Whoa, the back looks like the front.
Did you also think the back of the mask was the front? If so, that's a completely normal response.
My eyes and my brain were both playing a trick on me at the same time.
Just about everyone we showed this mask to couldn't tell the back from the front. But why is that?
The hollow face illusion reveals something that our visual system does quite well, which is to try and make sense of the world in the most typical way it can. We're used to seeing normal faces, not faces that are hollowed out. And your visual system assumes that when it gets something ambiguous that could be a face, that it must be a face.
Great.
So what other visual...
All right. So that kind of tells you a little bit, especially if somebody has an injury, a stroke, they really have some disruption to their perception. Okay, and we're normal and we're having trouble with this. So, okay. So visual perception, actually there's a couple things we want to discriminate, is unilateral visual inattention, and visual spatial awareness. I think a lot of us have the same problem. That is not my car. But you'll notice patients who walk or they're veering to the side, they really have some spatial difficulties, or they may be undershooting, overshooting, and it's not related to their eyes at all. Their ability to analyze what they see, knowing the foreground from the background, being able to discern everything. Many of these patients will have difficulty in a grocery store, or not being able to know where things are just because it looks just all one blank, messy thing to them. And then visual construction. Can they put parts together and mentally and be able to make sense of that? So this is an example of neglect or inattention. You probably have seen patients like this. Their gaze is off to one side. They can't even turn their eyes, and it's not related to a structure of their eye that's a problem. They'll eat and they'll only eat half the plate. If you ask them to draw a clock, you can see that they will only draw parts of it, and that's a common test. Okay, so you can play the next one, Andrew.
Which they want. You must always eat on the right side, but not the left side. Just leave that.
Give her a dinner plate and she'd only eat the vegetables and leave the meat, which is disappointing because I was a cook.
So if you start a picture, it can not fit in the paper if it gets over to the left because it hasn't left enough room.
Spatial neglect is a syndrome, that is signs and symptoms that patients most frequently have after stroke, but sometimes in forms of Alzheimer's disease, where they ignore one side of space. So people, objects, and sounds on one side tend to get ignored, and the patients who have it tend to be drawn to the other side. And this can extend to things like the food on the plate in front of them, that they'll only eat food on this side and then say they're finished. It may extend to parts of their own body. So when trying to shave, they may only shave this side of the face and miss out this. See the lines there?
Straight in the middle.
Yeah, that's one end, that's the other end. Show me where the middle is. Mark the middle for me.
I was only looking at a line from there to there. It's in the middle of my line, not the middle of your line.
So the first time I saw you, that's where you were marking this on top of them. So patients realise something's wrong when things are pointed out to them over and over and over again. So in a way, I think for them it's slightly abstract, that they know that there's some problem on the left-hand side and they're not aware of that problem, but they know everybody's telling them they have to do something more on the left. And so they use strategies, things like that, to try and overcome the problem without.
Okay, so with unilateral visual inattention, they tend to neglect things on the right or the left side. This is not a visual loss, okay? So how you can observe the patient during their normal task is if they have no deficits, you'll see them actively turning their eyes and their head to the stimulus. If they have a partial defect, you'll see that once in a while they'll pay attention, sometimes they don't, but it's not consistent. And if they have a severe defect, you'll notice that they will, their world has tilted because they don't believe this exists. So you'll see them lean. Okay, it's not a balance problem. It's because their world is completely shifted and they think that's the middle. So you'll see them tilt their head or just have trouble. They'll walk like here because they believe it to be the new middle for them. Some of the things you can do, like the neurologist did, was a line bisection test. Really simple. You can tell they miss it every time. They can't put it right in the middle. A copying test, like draw a clock or a person. And then there's some more objective tests, a behavioral inattention test and a letter of cancellation test. Okay. So what you can do for them for inattention is their behaviors kind of tell you if it's inattention or visual deficits. People with a visual field cut will tell you, I cannot see it. It's in their language. Versus somebody who has inattention, they're like, no, I don't know what you mean. It's not there. You know, it's much more vague in their language because in their mind, they believe this to be what is a representation of what they know. So they'll have like more of an asymmetrical searching pattern. If you put something on the table and they'll kind of randomly search. The person with the field cut will be more abbreviated and stay to the blind field. The inattention person, they really don't make an attempt to search to that inattentive side, but the people with field cut, because they're fairly cognitively intact, they'll search to the blind side. And the person with inattention they're not very accurate, they really don't care, they do it quickly, versus the person with a field cut, they tend to be more precise and check for things. Okay, so treatments for visual inattention, there's a restorative approach where we want to try to improve their ability. And then the adaptive approach is just to try to help them function. We're not trying to restore that. So helping them understand their difficulties is a restorative approach. You want them to have a linear or clockwise scanning ability, having them sustain attention. You may want to kind of constrain the area that they like to go to, so it forces them to go to their neglected side, and provide multisensory cueing. It can be touch, it can be temperature, but get them to cue over to the other side. And then an adaptive approach is just really having compensatory scanning, cueing them, having them place things in their field that they can see, but that's, like I said, is more of an adaptive approach, and we want to try to restore them. So someone with spatial deficits, they're not able to see differences in position, direction, angles, or rotation. They would have trouble with navigation. You can see that looks like most people's pantries. And just placement of things, like they won't know before, up, over, to the side. Placement of things would not make sense for them. Okay. So the test for that, what you'll see is if they're correctly placing things or orienting themselves, then there's no deficit. But they're only intermittently able to do that, then they have partial deficit. And if they have a severe deficit, they are unable to, they misalign quite a bit, they twist objects, they need a lot of help. Some of the tests is the cross test, trail makings test, and judgment of line orientation test. So again, 2 approaches, restorative and adaptive approaches. For spatial relations, you want them to retrieve items based on location. For instance, get your brush on top of the drawer. Do they know that's top, bottom? Okay. Use landmarks so they can have orientation, you know, stop at the stop sign on the left, and then move your body 90 degrees. Reference cues and variations in size and orientation, and provide them with tactile and kinesthetic guidance. Now, if you're wanting to provide an adaptive approach, you want to organize things in the same place all times, put markers on locations. I love blue painter's tape. I have them mark spots in their houses and corners, doorways, because they always run into things. And it's a cheap way to help them make sure that they're safer at home. Okay. So visual synthesis, we have difficulty with discrimination and recognition of objects and features. So if something's partially occluded, like the stop sign, they won't know that that's a stop sign, okay? Or if somebody's driving you might have a very high level patient who has a visual synthesis problem. If somebody's standing next to a bush, they actually don't know that the person's there because they cannot complete the picture. Junky drawers would be difficult for them. Putting things together would be hard. So a test for that would be to kind of look at if they can see different abstract shapes. Can they see something in a junk drawer or an I Spy, game? If they have intermittent ability, that's of course, they have a partial deficit. And if they're missing things 50% of the time, then they have a pretty severe deficit. And there's some formal tests, the Hooper Visual Organization Test and the Ayers Figure Ground Test. Okay. So some similar approaches, of course, we're gonna let them know that they have a problem and so they can understand their situation better. We wanna provide enhanced sensory input so that they can perform better. And that would be more of a restorative approach. You can alternate the task with vision and then take the vision away to see if they can manage a little bit better. And then adaptive approaches would be kind of placing things right where they can distinguish things, label things. Use of contrast colors would help so things pop out for them, and just kind of limit how much is available for them to sort out. Okay. And this is problems with visual construction. It's the difficulty in being able to build and understand the stimulus. If we are all people who go to IKEA, we can never build it, so you can tell them to build it for you. But you'll see these people cannot figure out like how to tie their shoes, or their covers are always messed up. They don't know how to turn them around. They can't put parts together, and they might be a very high level person, but it's very frustrating for them. They don't know why they're having this problem. Okay, So with visual construction, you are looking at the synthesis and discrimination. Can they like wrap a package or arrange flowers? Those are some kind of functional tests. Can they put a lid on? Can they put a letter in an envelope? Can they put like a 3-piece sandwich together? Those would be construction activities for them. Okay. So a restorative approach and an adaptive approach, they tend to be fairly similar, but then, you know, again, let people know. We tend to not let patients know what's going on. We kind of say, oh, you know, you have this, but we don't give them good education precisely of what's happening. I think knowledge is pretty powerful, and people can make good gains if they know how and what to do. So, okay. I'm hoping that the treatment references I gave you get you started. I know I'm talking very fast and it's a big topic. I could probably go for days on this, but we all kind of share the same objective of improving our patients' lives. You know, everyone is living longer, and the brain doesn't stop at an age. It's really dependent on our experience, and we can give them good experiences that help them make these neural connections. I have an aunt who's 106 and lives all by herself. And I just saw her in San Francisco. She lives in a 3-level home. So her hearing's not very good, but otherwise she's very intact, but she's very engaged. And I really think it's her activity level. How many of you know how many repetitions it takes to make a neural connection? I don't have a prize, I only have a cough drop, but. So they did studies with animals. It takes 400 repetitions to lay a pathway. Okay, so when we go in, we ask the patient to do something 10 times. Do you think that's going to be enough? Okay, so frequent orientation, especially for cognition, making them aware, let them practice when they're in the room. I know we can't always mobilize a patient, but we can stimulate their cognitive and visual capabilities on a regular basis. So the other things that will contribute to kind of more of a comprehensive stroke treatment is really understanding apraxia, which is motor planning, aphasias, and sensory deficits. And, you know, so I would encourage you to kind of see the other pieces that really contribute to the overall treatment of the patient. Okay, any questions at all? Are you ready for breaks?
Okay, so we have sort of a long break right now. What we're going to do, the next couple of sessions are actually going to be a lot of fun. They're very interactive. We're going to do a brain code and then sort of a code stroke session, and those are going to happen simultaneously, and then you'll go to one group and then we'll switch. So these 3 tables, so my coordinators in the back, and then Terry and Eugenia, and then you guys will all stay over there, and then everybody else will stay on this side. So you 3 tables will probably need to move your stuff because we have a divider that's going to be put out, so you may want to move your stuff over. But everybody else can kind of leave your stuff where it is. And we have probably about 30 minutes, 20 to 30 minute break to get the room set up. So just come back to the side that you're kind of assigned to.